Good morning, everyone. I would like to welcome each and every one of you for being here with us in this live session from MAHSA University, Saujana Putra campus. I am Manikandan Rangasamy, lecturer from Faculty of Health Sciences, MAHSA University, and I will be the moderator of today's session. Today's webinar, Fall Prevention Among Older Adults in Hospital Settings, is proudly organized by the Faculty of Health Sciences, MAHSA University. Dear viewers, before we proceed further, I would like to give you a brief overview of the programs offered by the Faculty of Health Science, Nursing and Education at MAHSA University. Yes, Faculty of Health Science, Nursing and Education is come under following departments: the School of Education, School of Physiotherapy, Department of Environmental Health, Department of Medical Imaging, and School of Nursing. Yes, yes. The School of Physiotherapy come under following programs: Diploma in Physiotherapy, Bachelor of Physiotherapy, Bachelor of Physiotherapy in ODL mode, and Master of Physiotherapy. Department of Environmental Health is having various programs: Diploma in Environmental Health, Bachelor degree, Bachelor in ODL mode, and Diploma in Occupational and Safety Health. Same like Department of Medical Imaging, Diploma in Medical Imaging, Bachelors and Bachelors in ODL mode. Right? Why you to join health sciences? Because health science job is having more demanded in this society, and it's a very low risk of job redundancy and opportunity to work in variety of settings and career you can feel good about, and lecture remunerations, so no boring of work routine. Right, come under the physiotherapy master of physiotherapy program. It's divided, we will give in two mode. One is a full-time mode, the other one is a part-time mode. Full-time mode is a 1 year and part-time mode is a 2 year. And what is the eligibility or entry requirements of bachelor's degree in, for master degree, bachelor degree in physiotherapy? Your CGPA supposed to be 2.5 and above. Or if it is less than 2.5, then you must have a 5 years of work experience in this relevant field. So if in international students, the IELTS scores must be 5.0 or TOEFL score must be 34. Right. Under physiotherapy, you have Bachelor of Physiotherapy is in direct mode and the Bachelor of Physiotherapy in ODL mode. And same like for the environmental health and safety is having the ODL and as well as direct mode. Same like for a bachelor degree in medical imaging, that also is available in direct mode as well as ODL mode. The entry requirements, okay, it's a minimum matriculation or pre-university or STPM or A level, or if the person may having diploma, if the CGPA supposed to be 2.75 and above, or they have a minimum 3 years. If the CGPA is less than 2.75, they must have a minimum 3 years of experience. Right. In our diploma programs, diploma in physiotherapy, diploma in environmental health, and diploma in medical imaging. So the entry requirements for these diploma programs, you must have a SPM or O level or certificate courses. The CGPA supposed to be 2.75 and above. So diploma in occupational and safety health, this program also is in 3 years program. It's a full-time program. The entry requirement is PM, O level, or your certificate in a health science program is the CGPA 2.5 and above. Right. So an inflate excellence is what MAHSA aspires to provide to each and every graduates. Right? Why choose Faculty of Health Science in MAHSA? Because MAHSA is having the experience and dedicated international pool of academic staffs and interactive teaching and learning skills, even face-to-face or online LMS mode, and wide list of hospitals and institutions are having the clinical placement and industrial training and accredited by the Malaysian Quality Association, Qualifying Association, and as well as cross-teaching and various studies modes as well as conventional mode as well as open and distance learning mode. Right. MAHSA, why we choose MAHSA? Because MAHSA providing various scholarship. Haji Abdullah Academic Excellence Scholarship and Foundation Scholarship, Blue Ribbon Scholarship, and School Teachers Scholarship, and Family Scholarship, the Single Parent Scholarship. Right. MAHSA is collaborating with the various collaborations and affiliation with various universities, World Confederation of Physical Therapy, Malaysian Physiotherapy Association, Anglia Ruskin University, and Lovely Professional University in India, Thailand, and China. Like that, various universities are collaborating and affiliation. Yes, we are providing various mobility programs. Okay, so student mobility program, we transfer the students, exchange the students from various universities. Lovely Professional University from India, and student mobility program from China and other countries. Right. So we welcome you all to join us. And for further, you want to know about MAHSA University and various programs provided by MAHSA, you can follow our Facebook page, Instagram page, as well as Twitter. And please contact us through MAHSA website or through our faculty Facebook page to know more about our programs. Your question concerning these webinar sessions can be listed into the chat box. Right. So today webinar, the Faculty of Health Science, Nursing and Education, School of Physiotherapy, MAHSA University will host a webinar. It's the titled as Falls Preventions Among Older Adults in Hospital Settings. So inpatient falls among older adults become huge challenges for healthcare practitioners in hospital settings, which can prolong the hospital stays and may lead to mortality. Identification of the risk factors and integrated multidisciplinary approach could provide comprehensive management for falls prevention and ensure the patient's safety in hospital setting. Join us this webinar to learn about falls prevention practice for geriatric individuals at hospital setting and role of multidisciplinary teams for falls prevention from our speaker, Ms. Thamayanthi. Now, let me introduce our today's speaker, Ms. Thamayanthi. Ms. Thamayanthi is a lecturer, School of Physiotherapy, Faculty of Health Sciences, Nursing and Education in MAHSA University. Ms. Thamayanthi graduated from Northumbria MAHSA University, BSc Hons in Physiotherapy Sciences in the year of 2013. She had 8 years of clinical experience working as a senior physiotherapist cum centers managers at private settings. She is treating mainly musculoskeletal and geriatric cases. Her research interest is falls prevention and gerontology. Currently, she is working as a physiotherapy lecturer in MAHSA University. I welcome Ms. Thamayanthi to proceed her webinar.
Thank you, Mr. Manikandan, for the briefing of the webinar. First of all, good morning all. I'm Thamayanthi here, physiotherapy lecturer from Faculty of Health Science. Firstly, I would like to thank to Professor Veronica Chua to give opportunity to present this webinar titled Fall Prevention Among Older Adults in Hospital Setting, and not forgotten our supportive colleagues of the Faculty of Science. So we're going to present the slides now. So this is the content of today's webinar. There'll be introduction of the aging and inpatient falls, fall risk factors. We've already discussed the fall risk factors, inpatient fall management, role of multidisciplinary team in fall prevention, various phase in effective fall management in Malaysia. So first we start with definition of falls. A fall is defined as an event which results in a person coming to rest inadvertently on the ground or floor or other level. So it can be tripping, sliding, even slipping also we can define as a falls. So falls are the major public health problem globally. In a year, fall costs 10 to 15% of all emergency department visits. Second leading cause of death due to unintentional injury. And there's a 684,000 fatalities happen because of the falls and loss of 38 million disability adjusted life year, 37.3 million presentation for medical attention, and 1.7 to 25 patients for 2,000 patient stays. In our country, this is a study conducted in a hospital Kuala Lumpur. They have found out that there's a 28.2% individual aged 61 to 70 had inpatient falls. So falls increase with age because of the condition, because of deteriorating health conditions. So as more they age, the system slows down and they have a tendency to have intrinsic issues. Okay, so they have a tendency to fall, and females fall often than men is because of at certain age, after 50 years old, they tend to have a menopause and can lead to decrease in estrogen level, and because of that it's affecting their bone, so they can have a osteoporosis. Okay, from osteoporosis they can have a even they can have a joint issues. Okay, for example, as a new osteoarthritis. So because of that, they can have a tendency to fall. Once patient already have a knee osteoarthritis, there's a more susceptibility for them to have a fall. So excuse me for the wordings. So falls in an older person is an important public health concern. In a year, it affects 28 to 42% of community dwelling older person. Community dwelling older persons is the older persons living in the community, not in a nursing home or community center. Okay, and 40 to 50% of those in long-term institutions. National Health Mobility Surveys in year 2018 in our countries recorded that 14.1% older adults had a fall in the past 12 months. Older adults twice as likely to fall than pre-elderly, and females fall more than males, and 37.9 suffer from recurrent falls within a year. So we see about effects of falls in an older adult. And HMS, National Health and Mobility Survey. So it shows that injury among fallers, 41.1% sustain minor injury, 18.4% sustain severe injury, and 16 require hospitalization. So falls makes up more than 50% of injury-related hospitalization. So it can lead to the consequences such as hip fracture, traumatic brain injury, and upper limb injury. So falls increased risk of hospitalization, means hospital stays. And inpatient fallers, they spend most of their time, most of the days in a hospital. So longest length of stay for the 420 days. So how an aging population can be defined? It can be defined as a less carers of working age adult taking care of the older person. So it been projected 3 times higher ratio of the older adult compared to working adult. And currently, in our country, we stuck in a sandwich generation or sandwich phenomena. It's then happened because of the working adult. They had a late marriage and they have young children. They have to take care of the young children as well as their aging parents. So they stuck in between. You can see from the picture itself. They stuck in between. They have to take care of them in terms of resources, time, and so on. So there's a huge burden on them. And next is there's a more falls and injuries, and means there's a more hospitalization, more hip fractures, It's may tend to be 3.6-fold by 2050. And aging population also can be defined as a decreased productivity and quality of life. So this is population pyramids in year 1980 in our country, Malaysia. So you can see from here, the birth rate is higher than aging populations. Okay, there's but the birth rate is higher. In recent year 2020, it's from the pyramid shape, it changed to the bell or dome shape. Okay, so we can we notice there's an increase of aging population. So what we can be concluded is the increase of longevity. And as time goes, I couldn't show the predicted population pyramid in year 2040. It's more like a tower shape. So it suggests that there is a more aging populations and there's a less birth rate, so which indicate that's a reduce in a fertility. So falls can lead to acute hip fractures, can happen because of most of them they have this osteoporotic conditions, and it's source of morbidity. Morbidity means associated illness, okay, morbid, and mortality means death. So 10 to 15% of falls result in fracture, including hip fracture, and even it can lead to the vertebral compression fracture. So mortality in hip fractures, 3 to 7% inpatient mortality, 3 to 10% within a 13-day mortality, and 2.4 to 34.8% 1-year mortality. So more than half unable to regain their pre-fracture mobility, and 60% will have difficulty with essential aerial activities after 1 year. So aging population on rise. So what can be done is to increase awareness on falls, educate on falls and fall prevention, craft pathways, and we prepare infrastructure for fall prevention. And multidisciplinary team consists of doctors, nurses, and other stakeholders. They have to take charge for the for management of falls for the aging population, or even for the geriatric care. So for the falls management, the first and foremost thing is we have to identify the fall risk factors. If you could identify the fall risk factor, we can design a comprehensive falls management. So there's two types. In general, there's two types. There's a modifiable and non-modifiable fall risk. So under modifiable, non-modifiable fall risk is the age, history of fall, dementia, disease process, alcohol and drug withdrawal. This one is that we can't change. Under modifiable is that fear of falling, clutter in the room, medication, bed rest, deconditioning, bladder catheters. So all of these are modifiable. So from there, I group it into three main fall risk factors. So extrinsic fall risk factor, there are two, environment and non-environment. So environment we know is the surrounding, and non-environment can be the type of shoes they're wearing, type of assistive device they're using, and so on. The next is for intrinsic is patient specific. Patient specific in terms of the conditions the patient having, like they having a vision issues, they having a hearing issues, vestibular problems, okay, they having a knee issues, and some of them having a conditions like a stroke, Parkinson, they can have the tendency to fall. So it's like more conditions, internal issues that patient having. So next, behavioral fall risk factor. This one we tend to take for granted. It's happened because of the patient's behavior itself, where they have fear of falling because they have tendency to lose of their balance, and they have fear of falling because maybe they have a jerk or they have a swaying of their body, so they have fear of falling. And it happened because of their behavior of turning also. Recently, I have a conversation with a matron at one of the hospital, and she said after an aged patient, his leg was amputated, he attempted to turn his body. He is not aware of his condition. He attempted to turn and body and he had a fall. So it depends on the patient himself, and sometimes because of their individual habits of use of alcohol and so on. So we see for now for the extrinsic risk factors. Under extrinsic risk factor, this is non-environment, the footwear. So what kind of footwear they are wearing? Something like slippers, okay? It tends to be so slippery. This kind of footwear is slippery. Some patients, female patients, they are wearing heels. So if you're wearing this kind of shoes or footwear in a hospital setting, they are more tendency to falls. Okay. And next is walking aid. So are they using a suitable walking aid based on their conditions or not? And sometimes there is an improper maintenance of the walking aid or walking assistive devices. So they have to take care of that, and it can happen because of lack of supervision and assistance and influence of the drugs, sedatives, and alcohol, which can lead to them to have a fall. And glasses, bifocal lens. So bifocal lens is used for presbyopia patients. So presbyopia is a condition, aging condition for the visual problem related to the aging. And bifocal lens has two sides. So one is for the short distance and one for the long distance. Because of this, it can have they can have issues with the visions. So it is better for them to have a meet optician annually so that we can reduce the risk of falls. So next is the important thing. I didn't group medication under extrinsic or intrinsic because it's affecting in three ways. So intrinsically, because of the polypharmacy. Polypharmacy means like more than 4 medications. There's more than 4 medications. It can influence the patients and it can lead to the orthostatic hypotension or dizziness. And so these all the drugs interact with each other, can lead to the dizziness. And sometimes, for example, the patients like Parkinson patients, they take antipsychotic medications and they can have hallucinations or psychosis, and this condition can lead them to have a fall because they couldn't figure out. So this condition can lead to falls. Next is the for increasing drugs I have explained just now. So fall risk assessment used in a hospital setting for older adult. In Malaysia, we have a lot of fall risk assessment tool, but this is the general one, and this is the one used in a hospital setting. And in Malaysia, as per falls guideline, nation falls guideline, they'll be using in hospital using MAHSA fall risk scale. So there's I'm going to explain the three main fall risk assessment tool. MAHSA fall risk scale, time up and go test, stopping elderly accident, death and injuries, steady. So first I'm going to explain about MAHSA fall risk scales. So MAHSA fall risk scale is a rapid and simple method of assessing a patient likelihood of falling. It's been used by nurses, mainly by the nurses, and usually they use in acute care. And from there, we have to check for the history of falling, secondary diagnosis, ambulatory aid, whether they're using an ambulatory aid, IV and heparin lock, but the gait and transferring and the mental status. And they can evaluate the patients, okay, based on the MFS score. So no risk means from 0 to 24, low risk means 25 to 50, even high risk means from more than 51 as per the MAHSA fall risk scale. Next, we go to the steady. So for the steady, it works on three principles: screen, assess, and intervene. So first, we have to do a general screening. Okay. After that, we have to assess the patient for the patient that having a modifiable risk factors in fall histories like gait issues, medications, from that increasing from Bayes criteria. Bayes criteria is the one is like a list of the harmful drugs that can lead to side effects. Okay, and ask about the potential home hazards. Usually, it's done by occupation therapists. and measure orthostatic blood pressure. When they change position, they tend hand to dizziness. And next is check visual acuity, assess feet and footwear, solve that. After that, based on the assessment, you can do the intervention. Okay, intervene to reduce identify risk factors using effective strategies like reduce identify fall risk. Then for the per gate, can refer to physical therapy. For the medications, the pharmacist can do the medication review, and for the orthostatic hypertension, they can observe the patient, okay, and they can check, monitor on the medications also, and educate the importance of the exercise like ankle pumping. I'm going to discuss later. So visual impairment, observe feet and footwear, and vitamin deficiency also observe, and because it's affecting the bone. And comorbidities are documented. Comorbidities like they had having a high blood pressure, depression, osteoporosis. So next is this one is time up and go test. It's quite a simple kind of a test to check for the patients, and equipment needed is armchair, tape measure, tape, stop, and stopwatch. The reason why they do the time up and go test is to evaluate the dynamic balance as well as to check whether the patient have tendency to fall. And we have begin the test with the subjects or patient sitting on a chair with the arms, and after that they have to walk 3 meters, okay, away from the chair to another chair. So they have to get instruction, go, you will stand up, then walk to the line on the floor, turn around and walk back to the chair, and sit down and walk at your regular pace. So when they're doing this time up and go test, is therapist or healthcare practitioner responsibility to be at their site, because this patient having tendency to fall, so it's like it's advisable for them to be at the site while this patient walking. And so after that, but before that, they have to do a rehearsal first. They have to do rehearsal. After that, only we check using a stopwatch. So normal healthy in elderly usually have less than 10 seconds. They can able to walk in 3 meters, okay. And if they have a tendency to fall, means it should more than a 12 or 30 seconds. So we see now, earlier we see the intrinsic risk factors. We see what the strategies can be done to improve the intrinsic risk factors. So for the intrinsic risk factors, we know that having an internal condition study, so we identify medical risk factors, optimize proper medication from them, and what can be done, the medical doctors can refer to the occupational therapists and physiotherapists, and they can have analgesics and can prescribe orthotics for them if it's required. So another thing I will highlight is postural hypertension. That's a drop of blood pressures like from 20 to 100 mmHg, and more than 20 to 100 mmHg is mainly because of the medication. One thing is sometimes can be because of the autonomic dysfunction. If present, address the drug taken. We have to check the medications and ask the patient to drink a glass of water 30 minutes before ambulations, and increase salt intake. And we can teach the calf muscle exercise to to improve the venous return. You can give the compression stockings, and you have to change position from supine to standing slowly. So we know it's like intrinsic risk factors, something like visuals and hearing also affected. So if required, make sure you're using hearing aids and glasses, not using a bifocal or multifocal lens. Make sure the room is well lit. You can use a visual aids. And like again, I highlighted osteoporosis risk factors, and they're having all of this issue: low bone mass density, deterioration of bone tissue, and all of this can lead to the increased risk factors. So what can be done is like to improve intake of the calciums, vitamin D. Okay, and they can do the weight bearing exercises. I didn't write down these strategies for that. So this can be done if we identify by the risk. So now we go to the extrinsic fall risk, this non-environmental fall risk. Make sure we have appropriate footwear. Avoid slippers. Use covered fastened shoes with thin hard soles with good grip, similar like sports shoe. And next is look for and address fall hazards. For the environmental modifications, chairs at the hospital settings should be an appropriate height, and there's a proper installation of grab bars, especially at the washroom, because the patients have a more tendency to fall inside the washroom. But recently, we have evidence that they tend to fall in their room as well. But it's better to doing a preventive measures for that. Next is for the extensive fall risk. Lock wheelchair before activity or transfer activity. There's a proper maintenance of the equipment of assistive device. Make sure the clothing is not loose or cover the feet. Because of this, it can lead to falls. Walking aid must be appropriate. So you can see from the picture here, this image that's taken from Ministry of Health Fall Guidelines 2019. So the A speeches like you can see with lines, catheters, and drains, A and B, and C and D is like more on the clothing and inappropriate footwear. You can see they are wearing slippers. And what else can be done is we can tag the patient. Okay, we can label them. We can tag the patient in their attire. The red color indicates high risk. Yellow color means moderate risk, and white color means low risk. So you can see from here they have put in a score. More fall scores like more than 45. This one is like moderate means yellow color is 25 to 45 is like less than 24 is for the white color. So another environmental modification is can be done is make sure suitable height of the bed so to facilitate transfers. Ensure the brake is on. Use bed rail is appropriate and teach patient how to open the bed rails. Okay, and for the patient is who is independent enough. And cabinet must be close to the bed so that object is easily reachable. And night light at the bedside. And there should be a call bell alarm reachable to the patients. And you can see the image at the right side. This is an initiative done by one of the private hospital. They have a place guideline preventive measures. Okay, the guidelines what can be done. So they should ask for assistance if they want to move and not simply move because they have a higher fall risk. So you can just have this chart at the bedside. It's going to be helpful for the patient with the pictures. Even it can be helpful for the carers or family members and they can follow accordingly. Another thing is proper technique for transferring. There's a proper binding and gripping techniques when we transfer the patient also important. And we can use a belt, okay, to transfer the patients for the heavy patients. And yes, sometimes the falls is unpreventable. So what can be done is we can have an anti-collision safety helmet, fall prevention mat, anti-slip fall prevention mat at the below of the bed, hospital bed, and lower bed height or mattress on the floor. So now we see the fall prevention practice based on MAHSA fall prevention program because in KKM, Ministry of Health, they use a MAHSA fall risks to measure the fall risk. So I'll be using based on that. So it's developed to prevent fall for hospitalized patients and provide basis in developing the other fall prevention program. So what we can be done is the first thing, orientate patient to environment and hospital, point out the location of the bathroom if the patient is confused, teach patient to call for assistance before get up from the bed. So the next is patient's education and for family education is important. Verbally inform patient and family about fall prevention intervention. And you have to monitor the patient risk status, okay, whether they have a high risk status or having low risk status. So next, we have to execute plan of care, cooperate with multidisciplinary teams in care plan. It should be tailored program for each patient because each patient having a different kind of conditions and different kind of needs. So we have to tailor the program. So next is fall program sign at the entrance to the patient room. And it is advisable to do comfort rounds every 2 hours to monitor the patient. Okay. So it's taken from Sinuraya. 2016. And this is the reason one from world guidelines, okay, world guideline for the fall prevention practice. The study was conducted year 2022. So they have put like in this way. So if the patient having a low risk falls for geriatric patients, we can offer education about fall prevention, exercise of fall prevention if interested. If they having intermediate risk falls, we can give education and offer targeted exercise, physiotherapist referral in order to improve balance and strength to reduce the falls. And having a high risk means they have to go for multi-factor risk assessment. It's more like a multidisciplinary team role comes here and to inform individualized tailored intervention. So now I'm going to explain further each of the role of the multidisciplinary teams in fall prevention. There is two, multidisciplinary teams and interdisciplinary team. Multidisciplinary team is the healthcare practitioners. Multidisciplinary teams is the healthcare practitioner who works toward the same goal, whereas whereas interdisciplinary teams, they works on their specific goals. So our main goal is fall prevention. So our multidisciplinary team approach for fall prevention, there is a few multidisciplinary teams members. So I'll introduce one by one. First, we start with nurses. So nurses play a huge role in fall prevention, and their role is to recognize patient fall risk factors, formulate individualized treatment plans, and manage patients who have fallen. So reassessment done by nurses, change in patients' conditions, okay, they have to monitor the patients, change in the medications immediately after a fall, identify any new fall risk, and implement appropriate intervention to prevent future falls. So this is the post-fall intervention flowchart from Inpatient Fall Guidelines 2019. So there is a few interventions, okay. If they're having a moderate fall risk interventions, they have to identify delirium and observe closely, check for the postural hypotension, manage appropriately, reinforce instruction to call for assistance, supervise and assist ambulation activities in daily living. So in summary, like all patient means in the can use the standardized fall risk interventions. For moderate risk means standardized and moderate fall risk interventions. High risk means standardized plus moderate and high fall risk is like combination. So next we move to physiotherapists. Physiotherapist assessment and intervention is a crucial part of fall care pathway. Assessment and intervention flowchart. First, we receive referral from the medical officer. So after that, we have to identify the central nervous system, vestibulocochlear system, and musculoskeletal issues that are affecting the falls. And we have to provide interventions based on, basically, we will do the strengthening exercise or balance exercise based on patient condition. Then after that, you have to do the assessment and post-intervention. Then after that, it's crucial for us to give an education on fall prevention and home exercise program to the patient. So next is occupational therapists. Occupational therapists is intervention to reduce fall in the older adult, mainly directed improving home safety and activities in daily living. Not forgotten, they involve in a cognitive rehabilitations also. So assessment and intervention procedure. Referral is received from the medical doctor. Assessment is performed by the occupational therapist. Physical and cognitive issues are identified. Intervention measures are initiated based on the issues identified. Patient is reassessed after the post-intervention. Education of fall prevention and home safety is given to those who have achieved occupational therapist goals or those who are the low risk of falls. Next is pharmacist role. Is this overlooked? Okay, is this overlooked or most of them fail to notice? They are indirectly involved in fall prevention. Okay, so it's a trained to conduct thorough medical reviews. So they're involved in medication reviews consisting of appraisal of age-related physical changes that predispose older adult to drug interaction, drug disease interactions, and medication side effects. So medication use is one of the most modifiable risk factors, and following pharmacy also involved because how the drug is going to interact, they're having more than 4 or 5 drugs. So how the assessment intervention procedure, first referral is received from the medical officer. After that, medication review evaluation performed by the pharmacist by comparing the medication history and current inpatient medication. Next is high risk drugs and far risk increasing drugs. Risks are identified according to the far risk assessment instrument. Intervention measures are initiated based on the issues identified. Patient reassess post-intervention, counseling and medication on use of the medication and changes in medication regimen are given before discharge. So we have discussed about everything, but there is some barrier faced for effective falls management in Malaysia. So whom to blame? Okay, it's seen in general. So healthcare practitioners and patients' view. So for the healthcare practitioners, related barriers like awareness for them and priorities in acute care in terms of lack of knowledge and skills, lacking training in adequate reference. So this is a healthcare practitioner related barriers. Healthcare practitioners perceive older people's related barriers. There's an underreported falls attached emotionally to certain medication, so they stick to that medication. They don't want to go further for the other intervention that benefits them. They are only focusing that doctors and or any certain kind of professionals only involved for their condition, treatment of the condition. Empathize falls as an aging problem. Falls are not a medical problem. Delayed medical attention. Most of them, they already have all these issues. After that, only they come for a falls treatments. So once they have just a red flag, if they're having a elderly patient having a knee issues, they won't have a susceptibility to fall. This is early sign. And another thing, language barriers. Okay, and sometimes some patients refuse to use assistive device. It's not from here. I have read in some one article. They refuse even through life experience also. I see the elderly patients. Some they want to use the assistive device because they perceive them as an aged individual. So they avoid from using assistive device and they have a fall. And next is apart from they have a logistic and system related barriers, assess problem to the physical therapy, time constraint, inaccurate reporting from family, reimbursement for evaluating falls, fragmentation of care and lack of coordination, lack of education material, and shortage of expertise. We're having a lack of geriatricians in our country, and even physiotherapists and other allied health professionals also lacking in fall prevention training. This is one of the but actually for the specific conditions like for the Parkinson's or high risk conditions, it's like I read from newspaper articles in year, I think I'm not sure, from year 2022. So in summary, the inpatient fall is a responsibility for the whole healthcare practitioners, include patient and their family. It's not for the specific, okay, fall prevention, only nursing professions are responsible for that. It's a responsibility of all. There's a need for tailored intervention that consider behavioral, intrinsic, and extrinsic risk factors and incorporate effective educational components. Fall risk assessments is initial step for fall prevention, but accuracy of fall risk assessment tool in hospital setting remain unclear and need to be tested. Various multifactorial fall prevention programs in acute setting have been designed, but the evidence of their effectiveness is limited and conflicting. So this is the reference I took for this webinar, and special thanks to Dr. Lim Wan Chia for his CME talk, Falls and Fall Prevention in Older Adult. I get a lot of information from his talk. Thank you and advance Happy New Year.
Yes, thank you, Ms. Thamayanthi, for the insightful presentation. Dear viewers, if you have any questions for Ms. Thamayanthi, please let a comment. Please fill in the survey form, which can be found in the comment section by the end of this webinar. e-certificate will be awarded. Yes, one question from Mr. Nelson Chia. Is there any exercise for falls, particularly for elder patients?
Thank you, Mr. Nyanchancha. Thank you, Mr. Manikandan. So, if the patient is having false issues, the first and foremost thing we do this individualized tailored program for them. But if you ask in terms of exercise, there's an exercise from New Zealand, Otago exercise program, which is comprises strength and balance, 17 strength and balance component, and is walking pattern. It can be conducted individually or by group exercise. Is most effective for the frail patient, frail elderly patient who have a tendency to falls. And first, the physiotherapist will do a basic screening or assessment first. After that, we will teach them exercises, okay, based on their capability. So that is the exercise. Hopefully, I answered your question. Otago exercise program. So again, we have a question from Mr.
Okay.
Nelson Chia.
Any other questions from audience?
From Mr. Nelson Chia, can you explain about falls prevention in elderly? So, so for the fall prevention in elderly, means is like in general should be a multifactorial fall prevention. So we have to identify the fall risk factors, and we can execute. Earlier, I have talked about the most fall risk for prevention. You can follow
Yeah,
this.
there is another question.
Yeah, you can follow that. Okay, thank you.
Yeah, can you explain about falls prevention in elderly?
Explain what is, sir.
Okay. Right.
Thank you.
Okay. So we came at the closing time. We have come to the end of the today's session. Thank you, Ms. Thamayanthi, for joining us today. Is providing such a insightful information. And to our wonderful audience, thank you for joining us in this webinar. So we look forward to your comments and participation at future events hosted by the MAHSA University. Please fill in the survey form, which can be found at the comment section by the end of this webinar. The e-certificate will be awarded. In case of any queries, you can contact us through MAHSA website or visit our social media. Have a pleasant weekend as well as a Happy New Year 2024. Salam Sajatra, Salam Satu Malaysia. Thank you.
Okay, happy New Year, Mr. Manikandan. Thank you.
Thank you. Thank you very much.
Welcome.